During an active ulcerative colitis flare, the mucosal lining of the gastrointestinal tract becomes deeply inflamed, raw, and ulcerated. The first-line clinical intervention for managing mild to moderate cases of this disease is 5-aminosalicylic acid, commonly known as mesalamine. Physicians also occasionally deploy it for specific cases of Crohn's disease when the inflammation is isolated to the colon. Chemically, 5-ASA is closely related to a household medication you already know, acetylsalicylic acid, or standard aspirin. Standard nonsteroidal anti-inflammatory drugs like aspirin operate systemically. You swallow them, they are absorbed deeply into your bloodstream, and they circulate to act throughout your entire body. This diagram illustrates the core pharmacokinetic difference. On the left, aspirin dissolves and circulates through the vascular network. On the right, 5-ASA takes an entirely different approach. It must be applied topically, resting directly on the mucosal lining of the gut to be effective. It does not need to enter the systemic bloodstream to reduce gut inflammation. This absolute reliance on direct physical contact with inflamed tissue dictates everything about how the drug is prescribed and engineered. Understanding this medication requires us to abandon the standard model of how pills work. We have to think purely in terms of targeted local delivery. In the treatment of inflammatory bowel disease, clinical success relies on the precise pharmaceutical engineering required to transport the delicate 5-ASA molecule safely past the harsh stomach acid and deploy it exactly where the anatomy is failing. To see why physical contact is required, we have to look down at the microscopic, cellular level of the intestinal lining. This visualization shows the primary biochemical drivers of gut inflammation. Here we see active cyclooxygenase, or COX, and lipooxygenase enzymes rapidly producing clusters of prostaglandins and leukotrienes. These are chemical messengers that signal and sustain tissue inflammation. When applied topically from the lumen side of the intestine, the 5-ASA molecule drops in and physically locks on to the COX enzymes. This binding causes an immediate halt in the local synthesis of prostaglandins. Simultaneously, 5-ASA binds to and inhibits the lipooxygenase enzymes. This shuts down leukotriene production, completely starving the inflammatory cascade at its source. The drug also serves a secondary functional role as a localized antioxidant within the gut environment. 5-ASA actively scavenges and neutralizes erratic free radicals floating near the mucosal surface, preventing further cellular damage. This tripartite mechanism, COX inhibition, lipooxygenase inhibition, and free radical scavenging, efficiently drives the tissue toward remission. 5-ASA is a highly effective biochemical silencer for colitis, but its power is entirely conditional. The molecule must physically reach the distal colon intact to do its job. Zooming out to the macroscopic level of the complete human digestive system, we encounter a severe anatomical roadblock. The stomach and the upper small intestine are highly acidic, absorptive environments designed to break down organic compounds. This 3D model demonstrates the problem. If a patient ingests raw, unprotected 5-ASA, the pill will dissolve prematurely in the stomach acid. The active drug is absorbed before it ever reaches the colon, resulting in complete therapeutic failure. The historical pharmaceutical workaround to this absorption problem was an older drug known as sulfasalazine. Sulfasalazine was formulated as a prodrug. It consisted of a 5-ASA molecule chemically tethered to a carrier molecule called sulfapyridine. This chemical tether allowed the sulfasalazine compound to survive the harsh stomach acid without being absorbed. Once the compound finally reached the colon, local bacterial enzymes cleaved the bond. This released the active 5-ASA exactly where the inflammation was occurring. The design was clever, but it had a critical flaw. While the 5-ASA stayed in the gut to treat the tissue, the detached sulfapyridine carrier was absorbed systemically into the patient's bloodstream. This systemic sulfapyridine triggered severe allergic reactions and acute side effects in a large percentage of the patient population. To fully harness the therapeutic power of 5-ASA, modern medicine had to abandon the toxic chemical carrier entirely and replace it with advanced physical engineering to improve patient tolerability. Modern mesalamine formulations solve this problem by achieving targeted delivery through engineered pH-dependent coatings and localized physical vectors, rather than chemical prodrugs. Looking at this 3D map of the colon and terminal ileum, we can see why targeting matters. Because the drug acts topically, the physician must match the exact physical formulation to the specific anatomical zone of the patient's inflammation. If the patient has widespread inflammation across the entire large intestine and terminal ileum, a condition known as pancolitis, the drug needs to cover a massive surface area. Here, delayed-release tablets or capsules are prescribed. Their coatings are engineered to bypass the stomach completely and dissolve strictly within these broad intestinal regions. If the inflammation is restricted exclusively to the left side of the colon, representing distal or left-sided colitis, an oral pill is less efficient. For this zone, mesalamine is administered via enemas. The fluid coats the tissue, mapping perfectly to the inflamed left-sided descending colon. Finally, we isolate just the rectum at the very end of the tract, representing a condition called proctitis. Here, suppositories are used to provide concentrated, localized deployment, specifically resolving this isolated rectal zone. A suppository physically cannot reach high enough to treat pancolitis, just as an oral delayed-release capsule is an inefficient way to target isolated proctitis. Treating inflammatory bowel disease with mesalamine is a strict exercise in precise geographical targeting. You must deploy the right vector to ensure the 5-ASA molecule physically touches every inflamed cell. While the goal is entirely localized action, we must pivot our focus back to the systemic vascular system to understand the clinical risks. Despite all the advanced topical engineering, trace amounts of 5-ASA are inevitably absorbed through the gut wall into the bloodstream. This slight systemic exposure can lead to common, generally mild side effects, such as headache, abdominal pain, nausea, or diarrhea. This diagram illustrates the rare but most serious consequence of this trace absorption: interstitial nephritis. As blood filters through the intricate nephrons of the kidney, these trace 5-ASA molecules can sometimes trigger structural renal impairment. Because of this risk, patients on long-term 5-ASA therapy require mandatory clinical monitoring to ensure their kidneys are filtering correctly. Clinicians will order periodic blood tests, specifically checking creatinine and blood urea nitrogen, or BUN, levels to verify renal function. There is a second rare clinical complication to monitor: mesalamine-induced acute intolerance syndrome. This syndrome presents a dangerous clinical paradox. It causes cramping, abdominal pain, and bloody diarrhea, visually mimicking the exact symptoms of a severe ulcerative colitis flare. Clinicians must be highly vigilant when a patient's condition worsens. They have to correctly differentiate between a failing drug that is allowing a true flare and a drug that is actively causing the failure through intolerance. 5-ASA's strictly topical nature makes it a highly tolerable and profoundly effective gold standard for inflammatory bowel disease. However, ensuring long-term patient safety relies entirely on continuous, rigorous clinical vigilance of systemic organ function.